Hi, everyone. Ooh, good morning. My name is Kiran Virdli. I'm an office practice nurse at Memorial Sloan Kettering Cancer Center. We have an exciting session ahead of us today, looking at variant pathology. But first, I would like to introduce Kathy Liu, president and founder of Joey's Wings, a nonprofit organization that raises funding for kidney cancer research, specifically for our younger patient population. Kathy?
Good morning, everyone. It's a great honor to be here today representing children and young adults affected by MIT family translocation renal cell carcinoma. I'm Kathy Liu, founder of Joey's Wings Foundation. I would like to start by sharing some facts of TRCC with you. So translocation renal cell carcinoma is the most common form of RCC in children and adolescents. It accounts for the majority of morbidity and mortality of all pediatric RCC subtypes. It's estimated that 20% of RCC patients who are younger than 40 have TRCC, and about 60 to 70% RCC patients who are younger than 21 have TRCC. Yet there's still no established medical treatment for children, adolescents, and young adults. This is my 10-year-old son, Joey, who passed away from TRCC at the age of 10 in 2014. He was overall a very healthy child, gifted student, maths champion, the youngest violinist in the county youth orchestra. And the tumor was found out during a normal physical checkup. So after 21 months of fight, he passed away in 2014. And I started Joey's Wings Foundation to continue his fight. We started our advocacy effort started with a very small Facebook group, and from 5 people to now about 20 people. We connected patients with medical professionals. We organized tissue donation and mentor patients and family. In 2015, I started to work with Dr. Argani, who named this cancer in 2004. We organized, by working together, we organized the world's largest documented collection of TRCC tumor bank. In the last 7 years, we helped fund TRCC research at Kidney Cancer Research Program at the UT Southwest. They have developed, just recently, they have developed the most comprehensive mouse model, and also created a TFE fusion cell lines that can be shared with other researchers. In 2019, with the Cancer Moonshot, NCI started my part, which is my pediatric and adult renal tumor network. Joey's Wings became my part's advocacy partner, and by working together, we connected my part researchers with adult kidney cancer specialists and children's oncology group. We also, Joey's Wings is also one of the members of Kidney Cancer Impact Alliance. We participated in the congressional meetings about the needs for CDMRP funding, and this young gentleman is one of Joey's best friends. Another important partnership is to be affiliated with KCA. We are very proud to co-found a Translocation RCC Focus Award, $75,000 earlier this year. And another thing very exciting for us, is a milestone for us, is this year we co-host the very first International TRCC Symposium in September with NCI and Cincinnati Children's Hospital. Besides our advocacy and funding research, we also provide financial assistance for families with a child diagnosed with kidney cancer, not just TRCC, but all type of pediatric kidney cancer. We typically fund 20 to 30 families a year. We give away a check of $1,000 for each family. And as you can see, we have children diagnosed with kidney cancer from the 2-month-old baby to 18 years old, and sadly, many of them are not here in this picture. There's so much need to be done in the future, and for Joey's Wings, our goal for next year is to form a TRCC research consortium by establishing working groups devoted to pathology, biology, and tumor model, and drug discovery, and clinical trial. register, etc. Our hope is to host regular meetings throughout the year before we meet next year for the second TRCC Symposium. So lastly, I want to encourage all of you, to do more research on TRCC, which is killing children and adults. As a mom losing a child, I lose almost all my dreams, but never a day did I lose a hope for a cure because each of you here. We are calling for more research on TRCC. We need to establish diagnostic standard. There should be no reason not testing TFE for patients who are younger than 40 years old. Yeah, it's a great honor to be here today. And if you are interested in studying TRCC or you know anyone who is interested, please reach out to Joey Swings. Thank you.
Thank you, Kathy. Your resilience is truly admirable, and we appreciate everything that you do. We have a great topic of discussion this morning, insights into variant pathology, where our pathologists will review how they diagnose unclassified RCC, such as translocation and papillary, and the challenges that they face. We will also have a debate on the pros and cons of molecular testing, followed by a Q&A at the end of the session, so please have your questions ready. I would like to introduce our panel today, Dr. Yasser Ged, Assistant Professor of Oncology at Johns Hopkins University, Dr. Sarah Wapker, Associate Professor and Director of Surgical Pathology at the University of North Carolina at Chapel Hill, Dr. Payal Kumar from UT Southwestern Medical Center, Associate Professor, and then Dr. Sonik Gupta, Associate Professor and Vice Chair of Oncology Practice at the Mayo Clinic in Rochester, Minnesota. I would like to start our session today with Dr. Ged, who will present on translocation RCC.
Good morning, everyone. I would like to start by thanking the organizing committee for the opportunity to present on translocation renal cell carcinoma. The learning objectives today is that I'm going to provide an overview of translocation renal cell carcinoma and an overview of systemic therapy options for metastatic translocation renal cell carcinoma. Translocation RCC is a rare RCC type, which was first officially recognized in the WHO 2004 renal tumors classification. It's characterized by gene fusions involving the MIT family of transcription factors, including TFA3, TFAB, TFAC, and MITF. And recently, it has been included in the molecularly defined renal carcinoma group within the WHO 2022 renal tumors classification. It's generally characterized by female predominance, ratio of 2:1, and it accounts for up to 40% of pediatric RCCs and 1.6 to 4% of adult RCCs. Prior exposure to cytotoxic chemotherapy is a risk factor for developing MIT family translocation RCCs. In terms of diagnosis, these tumors morphologically may resemble other RCC subtypes, although the most common pattern is papillary architecture with some homobodies. PAX2 and PAX8 are generally positive with occasional focal expression of melanocytic markers. And these tumors are also characterized by nuclear expression of TFA3, TFAB by immunohistochemistry, although these can be technically challenging with high false positivity. Break-apart FISH assays are the gold standard for diagnosis, and in selective cases, RNA sequencing may help to confirm the diagnosis. In recent years, with the expansion of molecular studies, there has been multiple efforts to understand these tumors at the molecular level. This is a study from Sloan Kettering, which looked at translocation RCC and also the kidney cancer, so the clear cell cohort and the papillary RCC cohort in the TCGA. And the investigators identified that these tumors generally have low tumor mutational burden. However, they have higher copy number alterations and genomic instability, which is one of the reasons for the aggressiveness of these tumors. In the same study as well, using immune deconvolution assays in the TCGA cohort, looking at gene signatures for angiogenesis, looking at CTLA4 and PD-L1 expression, the investigators found that the angiogenesis gene signatures in translocation RCC is higher than the papillary RCC patients, but slightly lower than clear cell patients. And looking at PD-L1 expression, these were in this cohort were higher in translocation RCC compared to the papillary and clear cell cohort in the TCGA. Another large effort from Dana-Farber were looking at patients at the transcriptome level, comparing translocation RCC to multiple other RCC subtypes. And in this study, the authors found that translocation RCC is characterized by frequent 9p21.3 deletion, which is present at the CDKN2A locus. And these tumors showed distinct transcriptional signatures different than other RCCs, which were mostly related to the lysosome biogenesis. And also, these tumors were characterized by activation of the NRF2 transcriptional factor pathway, which is generally leads to resistance to targeted therapies. Over the last 3 decades, there has been significant advances in RCC treatments, as depicted in this figure, and most of these treatments have been for clear cell RCC. And the development of treatments for non-clear cell RCC has been lagging behind, and historically, clear cell RCC treatments have been studied in non-clear cell RCC. In the next couple of slides, I'm going to present data for VEGF-TKI and immune checkpoint inhibitors in metastatic translocation RCC. However, most of the data that we have is retrospective in nature. Looking at VEGF-TKIs and ICI monotherapy data, this is a retrospective multi-institutional cohort of 24 translocation RCC patients. And in this study, most of the patients received sunitinib as the first-line VEGF-TKI, and all of the ICIs used in this study were monotherapy. For patients who received VEGF-TKI as first-line therapy, there were 19 out of 24 patients in this cohort, and the objective response rate was 10.5% with a median PFS of 3 months. Looking at ICIs as monotherapy used in the second-line and beyond setting, the objective response rate was 16.6 months and a median PFS of 2.5 months. Another cohort from Harvard, led by Bakuni, and in the same large in the same large molecular study that I mentioned earlier, and this also included a retrospective cohort of translocation RCC patients treated at different lines of therapy. There were 10 patients who received VEGF-TKI as monotherapy, and no objective responses were seen, and the median OS was 10.3 months. And looking at ICIs received as monotherapy and combination in this cohort in 12 patients, the objective response was 25%. The median OS was 62.4 months. Understandably, this is a small cohort of 12 patients. What about cabozantinib? Cabozantinib is known to be a potent VEGF-TKI, and specifically looking at cabozantinib data. This is a retrospective multi-institutional cohort of 52 translocation RCC patients treated with cabozantinib at different lines of therapy. And cabozantinib across multiple lines of therapy yielded an objective response rate of 17.3 months, a median PFS of 6.8 months, and median OS of 18.3 months. Moving into more contemporary treatment regimen that we use, specifically talking about ICI plus VEGF-TKI treatment. This was a single-arm phase 2 study of nivolumab plus cabozantinib in metastatic non-clear cell RCC as a single-site study in Sloan Kettering. And the study had 2 cohorts. Cohort 1 included patients who have papillary RCC, unclassified RCC, FH-deficient RCC, and translocation RCC. Cohort 2 included patients who have chromophobe kidney cancer. Across cohort 1, which included 40 patients, the objective response rate was 47.5%, median PFS 12.5 months, and median OS 28 months. There were 2 patients with translocation RCC as part of cohort 1, and with an objective response rate of 50%. Another important study is a phase 2 study of pembrolizumab plus lenvatinib in patients with metastatic non-clear cell RCC, which included 158 patients. And in this study, the objective response rate Across all, patients with non-clear cell histology was 49%, with a median PFS of 18 months, and median OS was not reached. There were 6 patients with translocation RCC in this cohort, and the objective response rate was 67%. What about comparing dual ICI therapy versus ICI plus TKI combination data? And this is a large initiative. It's a retrospective study of 29 patients with translocation RCC who received ICI combinations at multiple lines of therapy. The centers included in this study were based in the United States and France. And overall, the investigators found that there were better outcomes with ICI TKI combos in this disease. Looking at the ICI plus ICI dual combinations, there were 18 patients in this study with an objective response rate of 5.5%, median PFS of 2.8 months, and a median OS of 17.8 months. And looking at the ICI plus TKI data, the objective response rate was 36%, and a median PFS of 5.4 months, and a median OS of 30.7 months. Here at the IKCS, this is the first report of a new retrospective cohort that's going to add to the level of evidence that we have for this disease. And in this, I invite you to check our poster later on at the poster session. And in this study, we reported on a retrospective cohort of 22 translocation RCC patients who were treated with ICI combinations at any line of therapy. There were 4 participating centers in the US, including Hopkins, Sloan Kettering, Fox Chase, and City of Hope. And we observed similar efficacy outcomes in terms of higher objective response rates, better PFS in favor of the ICI plus TKI combos, but the median OS was numerically longer in the ICI plus ICI cohort. Specifically looking at the table for the dual ICIs in this study, there were 8 patients with an objective response rate of 14%, median PFS of 1.2 months, and median OS of 36.7 months. For the ICI plus TKI patients in this study, there were 14 patients, and the majority received pemaxitinib and nivo-cabo as part of those 14 patients. And the objective response rate was 54%, median PFS 6.2 months, and median OS was 15.6 months. So in conclusion, recent data on metastatic translocation RCC shows that these tumors respond well to immune checkpoint inhibitors with better outcomes on combinations of immune checkpoint inhibitors with VEGF TKIs. However, having said this, there still remains a high unmet need to identify novel therapeutic targets in this rare disease. Thank you.
Thank you, Dr. Ged. Up next, we have Dr. Sarah Wapker, who will present on understanding the unclassified.
All right, thank you everybody for joining today, and thank you for the invitation. I'm going to speak today about the use of and the reason why we have this unclassified category and what that actually means, and what the role of molecular categorization has been to discover unique renal cell subtypes. I'll use an example of papillary renal cell carcinoma, and then the emergence of a new category of molecularly defined renal carcinomas. And then from a pathologist point of view, to understand the initial workup of these tumors that don't fall into a nice category, and focus more on what we can do before we get to molecular. So I think it's important for everybody to understand what we're up against here and the true proliferation of renal neoplasms we've had. So in 1975, we had 2 entities, clear cell and papillary. And by 2022, we have more than 40 different renal tumors, many of which are defined by their molecular characteristics. So what is unclassified? For the purposes of making a diagnosis, this isn't a wastebasket. This is not one single subtype of renal carcinoma. It's really a group of tumors that we can't fit into another classification or categorization. So the latest WHO monograph actually designates these as renal cell carcinoma not otherwise specified, so you may see that in your reports as well. But I think it's important to note that as we study these tumors more, often using more molecular techniques, the percent of tumors that are unclassified or NOS is actually going down over time. So the example I have here on the right is an SDH-deficient renal cell carcinoma, which before we understood that this is a syndrome and something that we can actually easily test for with an IHC for SDHB, that it would be very easily to throw these into a category of unclassified. So, we are making strides into better categorization, but for our purposes of understanding what an RCC NOS is, these are typically reserved for large advanced tumors with high-grade features that might include sarcomatoid differentiation, where effectively the histology has deteriorated to the point that it's not recognizable, and then at that point we'd initiate some additional studies. But the example I wanted to bring up of how our understanding of renal cell carcinoma has changed over time is, the former categorization of papillary renal cell carcinomas into type 1 and type 2. And I think even the non-pathologists in the room can recognize that these look different. So the type 1 has this low cuboidal epithelium. They're often really abundant foamy histiocytes, so the clearer cells in the middle there. And it just looks, to me a little more blue as compared to the tumor on the right, which looks very pink. There's abundant eosinophilic or pink cytoplasm. The nuclei are quite pleomorphic, different sizes and shapes with really prominent nucleoli. So in the past, we would have referred to the tumor on the left as type 1 and the tumor on the right as type 2. But as we're, again, doing a lot more molecular characterization of these tumors, the TCGA, which was first done on the renal cell papillary group in 2016, showed that there really was a true distinct molecular profile for type 1 tumors that looked histologically type 1. Those showed MET alterations or chromosome 7/17 copy number alterations, and they, again, sort of fell into a nice category. But the type 2 group showed all sorts of different alterations. So CDKN2 silencing, SETD2 mutations, TFE3 fusions, and increased NRF2 pathway expression. So what this made us realize is that type 2 isn't one category. It's at least 3 different distinct subtypes, and that could actually explain some of the disparities in the clinical outcomes of those tumors. So not every type 2 is behaving the same way. And so as a result of this, the latest WHO classification no longer recommends the use of type 1 and type 2. So that will probably be falling off your reports. I wanted to show this figure from that TCGA paper, mostly because I think it does, again, sort of highlight how you can have one consistent group, type 1, and then you look at the tumors that were classified as type 2 by histology, and you see they have sort of multiple different alterations here. And interestingly, the FH, or fumarate hydratase, pathway is in the NRF2, and then the SMARCB1 in the SWI/SNF complex, which we now recognize as these molecularly defined renal carcinomas. So the latest WHO puts these into their own category, and their reasoning for this is that, as Dr. Ged made the point, that these can be very papillary in their histologic appearance, but they are not papillary renal cell carcinomas. So the phenotype-genotype correlation is not 100%, and we really need to be thinking about what are some more specific molecular alterations for these tumors. And just for completeness, this group includes the TFE3 rearranged, the TFEB altered, ELOC mutated, FH deficient, ALK rearranged, and SMARCB1 deficient renal cell carcinomas. Most of these are well, not most, but a subset of these are diagnosable on IHC alone. We have good markers for them. FH, SMARCB1, ALK rearranged, we can often get with the IHC. TFE3, TFEB, and ELOC all require some degree of molecular. So I'll finish up with a case example, and this is, again, to show kind of the process we're going through when we see these unusual tumors. So a 65-year-old woman with a 13-centimeter right renal mass. On resection, it involved the perirenal adipose tissue, so it's a T3A, and my initial sort of H&E diagnosis would be a high-grade renal cell carcinoma with oncocytic features, so very pink, and necrosis. So, this could easily fall into an unclassified or NOS, and, important things for me to note are nuclear grade, presence of adverse histologic features, et cetera. But I am going to try to get it into a more specific category. So doing an initial panel of immunohistochemistry stains, from the top left across, we've got just our H&E for comparison, a pan-keratin AE13, PAX8, which is to just confirm this is actually of renal origin, renal cortical origin, a CD117 or KIT. CA9 is our best biomarker for clear cell, cathepsin K, FH, and 2SC. So what these results show me is that this is not a chromophobe renal cell carcinoma. KIT is negative. It's not a clear cell renal cell carcinoma because CA9 is only positive in areas adjacent to the necrosis, and that has to do with the fact that this is a hypoxia-related protein. And then it's also not an FH-deficient renal cell carcinoma. We have intact FH staining, and 2SC is negative. So I think it would be very easy to stop here and just say this is a renal cell carcinoma, not otherwise specified. However, there is an interesting pattern here that is suggestive of something else. So the fact that the pan-keratin is patchy or negative in a carcinoma is fairly unusual. And then cathepsin K is my personal favorite biomarker, again, that would just suggest that this might be a translocation renal cell carcinoma. So the next step for me, based on that combination of weak to patchy pan-keratin staining and cathepsin K, is to send out for additional testing. So I sent this out, and the TFE3 FISH came back negative for rearrangement, so not a TFE3 rearranged renal cell carcinoma. And the TFEB FISH was also negative for rearrangement. However, when they do this and they look in the scope, they can see that there's an overrepresentation here of the green signal demonstrating TFEB amplification. So this is a somewhat newly recognized translocation-associated renal cell carcinoma, and is more likely to occur in adults and more likely to be quite aggressive. So we're recognizing more about these and their morphology. So our role as pathologists is basically to try and keep up with all of these new entities and make an accurate diagnosis based on our morphology and IHC profile, with the recognition that there are still some tumors out there that we can't definitively categorize. But if it's not categorizable, we do need to provide the clinicians with some data that may predict behavior or prompt ancillary testing. So things like nuclear grade, adverse features like sarcomatoid or rhabdoid features or necrosis. So we're really here to try and help guide the clinical management of the patient. And the take-home messages, after we've done our best, sort of recognize that there are additional studies that will be debated that may be useful. They may not be useful. It may be something where the surgery is sufficient, and unless it recurs or metastasizes, you don't need to know anymore. But I think it's very important that if we're giving you a diagnosis that doesn't quite align with your clinical impression, or you have additional data about family history or personal history of cytotoxic therapy as a child, things like that, please reach out to your pathologist and discuss that with them, because it may help them prompt additional testing that could further categorize the tumor.
Thank you so much. Thank you, Dr. Walker. Now we'll change things a little bit, and we'll have our next presentation on a molecular tumor debate on the pros and cons of molecular testing, and Dr. Kapoor is up.
Good morning, everyone. Thank you for joining me in this exciting discussion on pros and cons of molecular testing in kidney cancer. I think the prior two speakers have already done a phenomenal job of laying this work and arguing for what I'm supposed to do, but let me go ahead and further convince you on the pros of molecular testing. So in my opinion, molecular testing in kidney cancer offers several significant advantages. It helps in diagnosis, resolving challenging cases, molecularly defined RCCs, and genetic tumor syndromes. It also helps providing targets for therapy selection, better prognostics, prediction for immunotherapy, resistance management, and also clinical trial eligibility. So let me start with this first case, which is a 49-year-old male who had a left renal mass and enlarged retroperitoneal lymph nodes. The outside needle core biopsy was diagnosed as unclassified RCC. And what you can see here, these are representative slides from the resection. It doesn't have really a pattern which fits into our usual RCC subtypes. It's a high-grade tumor, has a lot of pink cytoplasm, prominent nucleoli, a lot of inflammatory cells. It does stain for PAX8, yes, favoring a renal origin, not a metastasis. Like the outside institution, we did a large battery of IHCs, and largely it was just positive for some keratin. Everything else turned out to be negative. However, we did send it for targeting sequencing, and it came back to have a ALK fusion with EML4, and also FISH analysis was positive. So this patient was diagnosed with ALK rearranged RCC. It is very important to make this diagnosis because there are targeted therapies that are available. And for the first time in 2022, WHO recognized this as one of the entities in the molecularly defined RCCs. Morphologically, it has a very heterogeneous pattern. It can also occur in a wide age range, including children. And therefore, thinking of it and getting molecular testing can really help you. And as a proof of principle, there was a paper by Monty's group where they showed that 3 patients who had ALK rearranged RCCs did not respond to conventional therapies, a large number of them, but had significant reduction in their tumor when given ALK inhibitors. In addition, molecular testing can also help with resistance. So here I show the image from sequencing data of a patient who we have reported before, who was on belzutifan. Most of his metastatic tumors responded till one of them started to grow. And sequencing from that tumor that stopped responded showed resistance mutation as shown here. Going to my second, my second case, which is a 63-year-old male who underwent nephrectomy in our institution. The morphology of this patient was papillary with pink and white cells, had a very prominent stroma. It was CK7 diffusely positive, which you don't see in clear cells. CA9 was also membranous positive, which we do see in clear cell. GATA3, high molecular weight keratin were negative. So these are helpful markers for clear cell papillary renal cell tumor. So it did not favor that diagnosis. So basically, it fit into a category which is a descriptive terminology of RCC with prominent leiomyomatostroma. It has a large differential, including 2 tumors, which can be seen in TSC syndromic patients, and also in tumors which have T submutation. And you cannot morphologically or by IHC differentiate these. This patient went on to have sequencing which did show ELOC or TSEB1 mutation, which generally occurs in hotspot, and there's also monosomy 8. These are rare tumors, but they can metastasize, so can TSC-associated tumors, but as you can see, the pathways would be quite different, and perhaps they could be managed quite differently. So over the last 2 decades, as we have done more and more sequencing, our knowledge of these tumors have grown. We have ended up having a more refined RCC categories, and for the first time in the 22 WHO classification, the molecularly defined RCCs were recognized, and you need molecular testing to make a definite diagnosis of this group. Beyond these group, molecular testing can also help with more accurate diagnosis. For example, mucinous tubular and spindle cell carcinoma can have features which closely resemble papillary renal cell carcinoma. However, their copy number pattern is very different, so they have large number of chromosomal losses, while papillary RCC has gain of 717. So just a simple SNP array can help you differentiate in difficult to classify tumors. Similarly, this is a newly recognized or newly developing entity of biphasic hyalinizing cymomatous RCC. These tumors can have a very different architecture. These are very aggressive tumors, but they do seem to have frequent NF2 driver mutations. And that is significant because they could, like other tumors, non-clear cell, especially mesothelium, where tumors which have NF2 mutation are more sensitive to NF pathway inhibitors. Moving to my third case, so this was a case that was sent from my prior fellow to me, a 56-year-old female with a large 10-centimeter infiltrating mass. She also had lymph nodes and liver metastasis. It was resected in his institution, and what he saw was this very papillary tumor with large nuclei, prominent nucleoli with this perinucleolar clearing. He was very happy to see that. He thought he could diagnose it. He got FH staining, fumarate hydratase, that came back as positive. So he sent it to me, and he said, you know, I thought this would be an FH deficient tumor, but it is not. So we did targeted sequencing, and indeed there was an FH mutation. It was a missense mutation resulting in a non-functional protein, but which was detected by IHC. So around 15% of FH deficient RCCs can have this. But it also led to germline testing, and she was found to have a germline FH mutation. Her family was tested. Her 26-year-old daughter ended up having also a big, huge renal mass, and I don't have images to show, but it was very infiltrative in a 26-year-old. So it's little, so just highlights the significance of making the right diagnosis because it has an impact on the patient. This patient has one tumor, not multiple tumors bilateral, which is generally at a young age. So it's features that clue you in as to a familial predisposing tumor were not present. Here's another case sent by the same fellow actually a few days back. This was a biopsy from a 42-year-old, and as you can see, there was a papillary tumor. It was Paxate positive. There was a little bit staining with MART1, and so he thought of translocation RCC. However, FISH was negative. And so he sent it asking about that, and we did get sequencing, and indeed there was a TFE3 translocation. So there can be a diagnostic pitfall with FISH when there is a cryptic isochromosomal XP11.2 inversion. And I've listed the common genes which it includes, and it can be as high as 18% of translocation RCCs can have a translocation with these genes. So this can also have implications in clinical trials. Here I'm showing you data from the iMotion 151, where the inclusion criteria was clear cell RCC, and 15 cases, around 2% of the cases were actually ended up being translocation RCC, and there's an impact in how they're responding to the two arms of therapy. So when we are just calling it clear cell type, we can end up enrolling patients who are not really clear, the type we want to include. Partners of, so even though we just call TFE3, TFEB translocation RCC, the partner may also have implications, prognostic implications. Here's data from our institution showing that ASPS, and this has been shown by other institutions also, tend to be more aggressive, while if the partner is SFPQ or MET15, these tend to behave more indolently. Similar molecular testing in other RCC subtypes can also be independently prognostic, and I'm just showing BAP1 here, for example, which in small renal masses ends up being an independent prognostic variable. Also, gene expression signatures can help us guide the therapies. So for example, if you have an angio-high tumor, you may choose to use TKI combination with IO versus not. And the mutations similarly also seem to be showing differences in response. So in summary, kidney cancer is a complex disease with several different subtypes. Molecular testing is increasingly being used to guide treatment decisions, especially in a context of genetic tumor syndromes, small renal masses where active surveillance is being considered, metastatic tumors, and for accurate classification. And molecular testing allows for personalized medicine, and its understanding can lead to more effective therapies and better patient outcomes. Thank you all.
Thank you. And now we have Dr. Gupta, who will have his presentation on the cons of molecular testing.
Thank you for the invitation. I think most of the cons regarding molecular testing come back to the question of cost of testing, access to testing. I just think back to a conversation I had with an insurance company about a week ago, asking us why we had 5 genes on our melanoma panel when 2 genes would suffice. So we practice in this environment where people are not willing to reimburse for molecular tests. So clearly cost and access is an issue. The number of targets we're looking for keeps expanding. Not only are we looking at SNVs and copy number changes, and the list of genes continues to grow, but we're also looking at methylation, gene rearrangements, and so it is complex. Instead, what I wanted to do is maybe give you a snapshot of some real-world cases where molecular testing in isolation may not be sufficient, and to just kind of highlight some pitfalls. So as I go through this, I'll maybe focus in on one molecularly defined kidney tumor type, and discuss some immunohistochemistry-based surrogates, some of which Dr. Kapoor touched upon, and also kind of emphasize, let's say, the role of integrating traditional histology and immunohistochemistry with more advanced molecular testing. So I wanted to take a minute to talk about HLRCC, which, as you're all aware, is associated with fumarate hydratase or FH alterations. You can have cutaneous leiomyomas, uterine leiomyomas, kidney tumors. Some of the other FH deficient tumor types that we're starting to recognize include pheochromocytomas, paragangliomas, testicular Leydig cell tumors, and even gliomas at this point. But of course, our primary focus is on the kidney tumors, which are extremely aggressive. And the mean age at presentation for HLRCC patients is roughly the mid-40s. And having said that, the majority of these FH-deficient tumors that we see in our practice are generally sporadic tumors occurring in much older patients. I think this is a fairly representative image of what we would consider an FH-deficient renal cell carcinoma, but it only represents a subset of these cases. While most of these have papillary architecture with these prominent nucleoli, a lot of these tumors don't. Some of these tumors represent or show morphologic overlap with tumors that look like oncocytomas or tumors that look like acquired cystic disease type RCC. So there is a fairly wide morphologic spectrum to these tumors, and we all recognize that FH-deficient tumors, for instance, have very poor outcomes. And when we look at historic data on tumors graded as type or grade 4 papillary RCCs, there's a good chance that a large number of those tumors actually represent FH-deficient tumors, either in the germline setting or in the sporadic setting. And I apologize for showing you an image of the Krebs cycle, but I'll keep it short. All I wanted to show you was maybe the F8 gene, and as Dr. Kapoor mentioned, most of these tumors, when they have an FH pathogenic mutation, have loss of the FH protein, and this allows us to pick these out. And if you look at the Krebs cycle, the last time I'm going to ask you to look at this, there is an accumulation of succinate in tumors that lack FH mutation, so you have this global succination. And so you can use immunohistochemistry for this marker called 2SC. So in combination, FH and 2SC can help you screen for these tests. So now that we have these fancy immunohistochemistry tools, let's go ahead and try it out on a test case, very similar to the one that Dr. Kapoor just showed. This patient presented with HLRCC. So interestingly, this patient had a kidney tumor at the age of 48, but when I looked through this patient's chart, had cutaneous leiomyomas that were diagnosed maybe 10 years previously, and nobody had made the connection. But once this patient had a kidney tumor, underwent germline testing, and identified a pathogenic mutation. Here you can see that the FH protein is not lost. So likely a dysfunctional protein, but with retained FH expression. Similarly, in the kidney tumor, the FH protein is not lost, and you use the combination of FH and 2SC, you can make the right diagnosis. So now I'll show you a real-world example where things can get maybe a little complicated. So we have a pediatric patient with a kidney tumor, and so with pediatric patients, you would want to go ahead and do germline testing. And so in this case, and this was a few years ago, this variant was reported out by a commercial company as a likely pathogenic variant in the F8 gene. And here is the nephrectomy specimen, and you can see that there's roughly a 2-centimeter tumor, and it's very unusual because this is arising from the collecting system. So if you were to stage this because of collecting system involvement, this would be a PT3A, and it looks papillary. So you have a pediatric patient with a likely pathogenic FH variant, a papillary tumor, potentially PT3A. And the interesting part about this was the FH protein was not lost and 2SC was not elevated. So this kind of drives you into a situation where you want to ask yourself, which do you trust? Do you trust the molecular results? Do you trust the immunohistochemistry? And this can be complicated, right? And fast forward a few months, we came across another patient with the same FH variant. And in panels D, E, and F, you can see a biopsy from the same tumor. And so this was a relatively small clear cell renal cell carcinoma that was ablated. And around the same time, there was a study from Memorial Sloan Kettering saying that this variant was seen in roughly 20-odd patients, and none of them actually had kidney cancer. And while we did identify 2 such patients with kidney tumors, neither of them had the immunophenotype that you would expect of FH-deficient tumors. So since then, this variant has been reclassified from likely pathogenic to a variant of uncertain significance. And it's a big deal for the patient, right? Because now not only are you counseling the patient, you're counseling the entire family with regards to the germline implications here. And I just want to maybe take a minute to highlight that the same gene is responsible for 2 completely different disease states. You have the monoallelic FH alteration, which is associated with an autosomal dominant HLRCC disorder, where you get the kidney tumors. And then again, you have fumarase deficiency, which is an autosomal recessive disorder, where these patients have either a homozygous alteration or a compound heterozygous state. And this is a completely different disease. These patients present with encephalopathy, with developmental delays, infant onset seizures, fumaric aciduria. So, and they generally don't present with kidney tumors. So 2 completely different disease states associated with the same gene. Here is a study from that summarizes about 7 years of testing for FH alterations published by a commercial lab, Ambry. And here, going from left to right, you can see the FH protein, the N to the C terminus. At the bottom, you have the alterations in red, which are the truncating alterations. Most of these are associated with the HLRCC. On the top, you have the alterations in blue, which represent maybe missense alterations. And some of these, the ones that have been highlighted with the triangles, are actually not associated with the autosomal dominant disorder, but are associated with the autosomal recessive disorder. And the one that I just highlighted, this can have a fairly high population frequency, up to 0.5% in Ashkenazi Jewish populations. So something to be aware of. So in summary, I just want to emphasize again that while molecular testing is really helpful for multiple reasons, again, we have to interpret it in the context of the traditional histologic and immunophenotypic findings. Something that we are running into more and more of late is that a lot of patients will have sequencing results available in parallel with their pathology results, and sometimes, like in the case that I showed you, we have to kind of figure out, is this, let's say, a syndromic tumor, or is this a sporadic tumor in a patient that just happens to have a gene alteration associated with an underlying hereditary predisposition syndrome. So with that, I'll be happy to take any questions. Thank you.
All right, I would like to thank all of our panelists today. Really enjoyed the case studies that you had all presented. We probably just have a few minutes for any questions. I see one there. Yes, go ahead.
Yeah, so this is for the pathologists, and maybe a bit provocative, but you know, you guys are the experts in diagnosis, and you've taught me over the years that what I thought was 1 or 2 diseases is now 3 dozen diseases, and I don't understand it, and I can't remember all the classifications, and a lot of the molecular testing is fundamentally diagnostic in nature. So why do, I'm going to blame you, but why do you make me order the molecular testing who doesn't even recognize a lymphocyte from an epithelial cell on an H&E slide?
I can take an attempt. I can make an attempt at this. I think some of it is regulatory. So when it comes down to the large panels, so let's say the 500 gene type panels from Foundation, Tempus, Caris, or other commercial companies, we are not allowed to order those, and this is a huge paradox. And what we have a relatively large amount of leeway with is ordering smaller focus tests, and not everybody has access to those. So to give you an example, let's say we have ambiguous immunohistochemistry results for FH, and we want to sequence for a single gene. Many places may not have access to a single gene assay. So then it becomes a question of, okay, now what do I do next? Let's go ahead and order a 500 gene panel, which is likely overkill, but that's just what may be available to somebody in their practice. And because of regulatory requirements, a pathologist may not be able to order that particular test. And so we would have to go and get your help in getting that ordered.
And I understand that. I actually appreciate all those things. I would just say that in 2023, it's time to change the model. I would say that it should be, why can a pathologist order 26 IHC tests but needs me to order a panel test of sequencing makes no sense, especially in this world of interdisciplinary care and modern medicine. And I'll leave that as a statement.
Thank you. Do we have any more questions or?
Yeah.
Yes? Oh, sorry. Yes, go ahead.
Yeah, thanks. I really enjoyed this session, and I'm so excited that we're really moving toward molecular testing. And but I think Walt's comment is very valuable about how much more we have to collaborate with our pathology colleagues in this space. So my question, though, is really, we are making these major advances, you know, at academic medical centers, experts like you who see kidney cancer all the time and can think really deeply about the 40+ types of kidney cancer that there are now. How much of this is making its way into the community? We know for care for patients with cancers, it's over half of patients are not seen at comprehensive cancer centers or places where they can get multidisciplinary care. What happens out in the community?
So I can take a stab at this. This is something that I really worry about. I really worry about access to testing. And when I think back at our experience at Mayo, we're fortunate to work with a reference lab. And to date, we've, just in the space of translocation RCCs, I think at last count, we've tested 3,500 patients in the past dozen years or so. And you know, tests like those are widely available, whether it's offered by us or by other groups. And mostly because they're single gene tests, they're relatively inexpensive. But now I think the first step is to allow pathologists to order molecular tests that are fairly cost effective. And I think it's a very difficult balance because people, at least from my perspective in academic medical centers, people don't want to hear about panel testing. They want whole genome testing, they want whole exome sequencing, and they say, I don't care about a 20-gene panel. But you may get a completely different answer from somebody working in a community hospital. And what we've decided is to try and build all of these and offer it to everybody and say, here is a single gene test, here is a small focus panel, and here is a large panel. Choose the one that fits your needs. And I think that kind of gets towards access to testing, if that's helpful.
Great, thanks.
That was a great question. Go ahead.
Yeah, two very short pragmatical questions for a medical oncologist like me. One, why did you remove type 1 papillary, which is quite an homogeneous group of patients, and not keep to non-type 1, which was very easy in the past? And second, we commonly use clear cell component as part of our inclusion criteria. Do you think we should definitively remove this inclusion criteria from our clinical trials?
I'm happy to address the first, and maybe Dr. Kapoor can do the second. So removing type 1 and type 2 really means that anything that's being called a papillary renal cell carcinoma probably fits more in the type 1 categorization. So the way I actually do it when I sign out a case is papillary renal cell carcinoma, and then I put a note that says basically in the past this would have been recognized as type 1. If it has the histology of what would have been a type 2, that's when I'm maybe looking at initiating some more testing and excluding things like FH or translocation carcinomas. And it does become a little bit of a comfort level and judgment call on how far you go with those type 2, quote, type 2s for these, exclusionary tests, because again, cost, access, I have to send out, if I'm thinking about a translocation, I have to send that out, and when is that always worth it? So for me, the tumors that remain papillary renal cell carcinoma are effectively the former type 1.
Yeah.
Great.
Regarding your second question, I'm completely in agreement with you. And this has been an effort being with Sabina, being part of the NCI task group and then NCCN. I think we've changed the wording a little bit and called it clear cell histology, but I do think it's still not as clear for somebody who may not realize that it should mean clear cell RCC, not any tumor which can have clear cell morphology. Thank you.
Thank you, and I think we have time for one last question.
Thank you, great session. So in line with the first comment, I think what we need is guidance from you on who and how we should test patients. Dr. Kapoor, you showed two very nice examples of patients that could have been misclassified, translocation, or even FH without the immunohistochemistry matching. And so, I mean, in any center, including high volume center, people would have missed these diagnoses, and you went beyond the recommendation to go for sequencing and so on. So we don't know who's going to prescribe that, and it may be different in different countries, but we need guidance on how we should screen our patients. And this is really in your hands now, the pathological field, to help us there. Thank you.
All right. That concludes our session. Thank you to our panelists for providing their insight and their expertise. We will now take a 10-minute break. Thank you.